Hello everyone, this is Dr. Madhusudan Rao on the program I teach medical students. Today my topic is beta thalassemia major. Thalassemias are the most common genetically transmitted hemolytic anemias. Beta thalassemia is due to the reduced synthesis of beta globin chain secondary to the mutation of the beta genes. There is one beta gene that is inherited to the child from each parent. Beta thalassemia major is an autosomal recessive disorder, and the individual receives one mutated gene from each parent, and the homozygous state manifests. Look at this child, a 7-year-old child with beta thalassemia major. There is marked bossing of the frontal and parietal bones and the zygoma, giving a mongoloid picture. Well, beta thalassemia is genetically transmitted hemolytic anemia associated with diminished or absent production of globin chains with variable clinical presentation. There is quantitative defect in the hemoglobin, not the qualitative, as we see in the children with sickle cell hemoglobinopathy. The hemoglobin is structurally normal, but it is quantitatively defective because mutation in the genes controlling the synthesis of the beta globin chains is the defect in the beta thalassemias. It is the most common genetic disorder. There are nearly more than 200 beta thalassemia variants. Okay, nearly 3% of the world population carry the gene for beta thalassemia. It is related to geographic distribution of malaria. That is, most of the tribal areas in India we see the children suffering from beta thalassemia. Poor children. They are quite away from the availability of the medical services. They suffer a lot of morbidity and mortality. Because of chronic hemolytic anemia, as the red cell lifespan is far below normal. There is higher concentration of fetal hemoglobin as there is reduction in the synthesis of beta chains. As a response, there is increased synthesis of fetal hemoglobin, that is gamma chains, which pairing with the alpha chains form the fetal hemoglobin. So the concentration of fetal hemoglobin is elevated, so much so the A2 levels, because A2 is formed by 2 alpha chains and 2 delta chains. Then the erythropoiesis is ineffective, and there is a progression of the process of erythropoiesis is very slow, thereby resulting in hypochromic microcytic anemia. And cells with the reduced beta globin chains, and there is increased synthesis of alpha chains, forming tetramers of the alpha chains in the red cell, which cause the damage to the cell membrane, and there is premature lysis of the RBC. So the cells, they die before they are released into the peripheral circulation. That results in the ineffective erythropoiesis, and the anemia is transfusion dependent, that in turn results in the iron overload and manifests as the transfusion hemosiderosis with multi-organ dysfunction and ultimately failure. The child with beta thalassemia, pity, the child suffers from morbidity secondary to the progressive anemia from the age of 6 months onwards, and he is transfusion dependent unless otherwise they suffer from effects of severe anemia and die of congestive heart failure if not provided with blood transfusion. What is the genetic basis of this particular disorder? As I told you, it is genetically transmitted autosomal recessive. It requires two abnormal genes in homozygous state to manifest. Okay. Genetically, they may be heterozygous, homozygous, or hemizygous. And thalassemia clinically presents with different expressions. There is variable expression of beta thalassemia. They may present as thalassemia major, or thalassemia intermedia, or thalassemia minima, or thalassemia minor, or thalassemia trait. So this way there is a lot of variation with regard to expression of the beta thalassemia. In all these conditions, there is mutation of the beta gene and there is reduced synthesis of beta globin chains. The variability is secondary to the extent or quantum of the beta globin that is synthesized, a product of the beta gene. Okay. A gene in a particular individual which is mutated may result in the complete absence of the beta globin chain, or in another individual there is partial reduction in the quantum of beta globin chain. So that results in the clinical variability in the form of thalassemia major, thalassemia intermedia, thalassemia minor, or trait. Well, coming to the molecular basis of thalassemia, there is beta gene cluster. Where they are located? Located on chromosome 11 at locus 6. Okay. Beta gene cluster. How many beta genes are there? There is epsilon gene is beta gene because it pairs with the lambda chain resulting in embryonic hemoglobin. Again, gamma chain is again a beta gene because it pairs with the alpha chain forming the fetal hemoglobin. Beta gene is beta gene. Delta is also related to beta gene because it pairs with the alpha gene to form the hemoglobin A2. That means total beta genes are 1 epsilon gene, 2 gamma genes, 1 beta gene, and 1 delta gene. Okay, we are interested in beta gene. That means there is 1 beta gene inherited from each parent to form the adult hemoglobin along with 2 alpha genes product, that is 2 alpha globin chains. So A2B2 is the configuration of adult hemoglobin. A2 delta 2 is the configuration of hemoglobin A2. A2 gamma 2 is the configuration of fetal hemoglobin. When the synthesis of beta globin is reduced as a result of the non-functioning beta gene and other beta genes they dominate, resulting in elevated level of the HbA2 or elevated level of fetal hemoglobin, that is A2 gamma 2. Okay, and there is imbalance in the synthesis of globin chains. There is excessive synthesis of alpha chains, resulting in alpha globin tetramers, which are toxic to the membrane of the RBC. And there is these RBCs, they die before they are released into the circulation. That results in ineffective erythropoiesis. Okay. So one beta gene on each chromosome inherited from each parent. Total two beta genes produce two beta globin chains to form the hemoglobin A, and beta slash B represent the genotype of normal beta chains. Okay, this is the genetics of beta thalassemia. Then what is abnormal? Once there is thalassemia major, it is a homozygous state. This homozygous state could be due to beta 0 or beta 0. That means there is no beta globin gene functional. There is no beta globin chain that is formed. Beta plus and beta plus. There is mutation of the beta gene, but the gene is functioning at a low level. Reduced function of the beta globin gene, that is beta plus and beta plus. This is again homozygous state. That is in thalassemia major with variable expression with reduced synthesis of beta globin chains. Beta 0 and beta plus. Again, the genes are defective. Both the genes are defective. Beta 0 gene is totally non-functional. Beta plus gene is again mutation gene with reduced function. So this is by and large it is a homozygous state resulting in thalassemia intermedia. Then there is heterozygous state, that is beta 0 and beta. That results in thalassemia minor or minimal. Beta plus and beta, one normal beta with beta plus reduced functioning beta gene, that is thalassemia trait. This is the genetics of thalassaemic syndromes, that is beta thalassemias. So what is the pathogenesis? As such, there is a defect in DNA. DNA is the segment, large structure, that is double helical structure, that is there in the chromosomes. And a segment of the DNA forms the gene. Okay, and there is a sequence of the nucleotides that are there over in the DNA molecule that results in the mutation of the gene, and its functionality will be disturbed. That results in the absent or diminished beta gene product, thereby resulting in reduced level of beta globin chains. There is associated excess alpha gene product, that is alpha globin tetramers are formed. They form the inclusions in the RBC. So that results in the damage to the cell membrane and hemolysis and anemia. RBC with these inclusions are destroyed prematurely within the bone marrow, resulting in hypoxia. In turn, erythroid hypoplasia secondary to the elevated levels of erythropoietin. Okay, that results in the bony deformities, characteristic feature of beta thalassemia major. Excess of gamma and delta gene products results in elevated HbF and HbA2. Okay. A2 and gamma 2 forms the fetal hemoglobin. A2 and delta 2 forms the HbA2. Both are relatively elevated in beta thalassemia major. because the erythropoiesis will not progress normally as it happens in the healthy individuals. This results in the ineffective erythropoiesis, and the anemia is treated by repeated blood transfusions. That in turn leads to the iron overload and hemosiderosis. As such, there is chronic hemolysis is happening. There is increased rate of absorption of iron from the gut, okay, because of the release of erythropoietin and inhibition of the hepcidin by the liver, and it adds to the increased absorption of iron from the gut, thereby resulting in hemosiderosis. Look at the beta thalassemia major patient with peripheral blood smear. Peripheral blood smear in this particular patient shows hypochromia, target cells, and there is what is that? Anisocytosis, poikilocytosis, and basophilic stippling in the peripheral smear of the patient with beta thalassemia. And look at this particular slide showing the pathway for pathogenesis of beta thalassemia. As such, what is happening in the beta thalassemia major? There is impaired beta globin chain synthesis secondary to the mutation of the beta globin chain gene. There is abnormal erythroblasts, and most of these RBC they die in the bone marrow, okay, resulting in ineffective erythropoiesis, which is the hallmark of beta thalassemia major. Few abnormal cells enter the circulation and precipitated alpha globin aggregates with the resulting in the membrane damage and extravascular hemolysis in the spleen. There is massive splenomegaly associated with anemia. There is tissue hypoxia, elevated erythropoietin levels. There is expansion of the bone marrow secondary to the erythropoietin hyperplasia, thereby resulting in skeletal deformities, a feature of thalassemic phases. There is extramedullary hemopoiesis resulting in hepatosplenomegaly. There is increased synthesis of erythropoietin resulting in the suppression of hepcidin. Okay, there is increased intestinal iron absorption secondary to the suppression of hepcidin. Added to the regular blood transfusions and the increased absorption of iron, there is systemic iron overload leading to hemochromatosis, cardiac hemosiderosis, and ultimately death. This is the pathway of beta thalassemia major, its pathogenesis. And how does the patient manifest? It can be described under three headlines. That is, general features of anemia associated with growth failure, easy fatigability, exercise intolerance, pallor, jaundice, and congestive heart failure and death. Well, this is the hemoglobin moiety of the RBC that is responsible for carrying the oxygen from the lungs to the tissues. When the tissues are deprived of adequate oxygen, okay, it results in growth failure. There is metabolic stress resulting in anaerobic glycolysis resulting in acidosis. As such, there is hypercatabolic state in the system as a result of chronic anemia and hypoxia. So that results in the growth failure and appearance of the patient with chronic anemia results in chronic cachectic appearance secondary to caloric waste. Yeah. So the patient will present with growth failure, easy fatigability, exercise intolerance, pallor, and jaundice, and ultimately death due to congestive heart failure. So, what are the features of beta thalassemia major and the features of transfusion hemosiderosis? Thalassemia major, the features specific to this particular condition includes thalassemic phases, that is, frontal bossing, depressed nasal bridge, parietal bossing, maxillary prominence because of zygomatic bossing, cachectic appearance because of the catabolic state of the individual, pathological fracture because of thinning of the bones due to widening of the marrow space, massive splenomegaly, okay, which is caused by compensatory hyperplasia of the erythroid tissue in bone marrow. And massive splenomegaly is secondary to the extramedullary erythropoiesis. So these are the features of specific for thalassemia. Features specific for hemosiderosis. There is continuous adding of the iron to the body. One, due to the increased absorption of iron from the gut, due to the fall in concentration of epsilon, and increased level of erythroferron, it leads to the adding of the iron to the body. When there is, as such, there is no exit for iron from the system. So that leads to continuous accumulation of iron in the tissues, resulting in hemosiderosis. Hepatic dysfunction sets in a year following the transfusion therapy. Endocrinopathy is secondary to the iron toxicity, starts nearly 4 to 5 years of transfusion therapy, presenting as hypothyroidism, hypoparathyroidism, growth hormone deficiency, diabetes mellitus because of the pancreatic hemosiderosis, gonadal failure, adrenal failure, cardiac dysfunction secondary to the cardiac hemosiderosis, ultimately resulting in death. What to do to the patient? Patient needs treatment to correct the hemoglobin level, improve the well-being, promote the growth, which again resulting in the accumulation of iron in the tissues, resulting in the tissue damage and the manifestations. So what to decide about it? So decide transfusion to avoid the bony deformities and institute chelation therapy when there is iron overload is mounting up to avoid damage to the organs. This should be the plan of treatment following the investigations. You see the X-ray chest, see the peripheral smear, analysis cytosis, target cells, and microcytic hypochromasia. This is the cardiomegaly, either secondary to the cardiac hemosiderosis or anemia with congestive heart. This is the X-ray skull showing the hair and appearance secondary to the widening of the diplo space due to erythroid hyperplasia. Do the hemoglobin, try to maintain the hemoglobin between 9 to 10% of 10 grams per cent. If you do the erythrocyte count, it will be usually less in proportion to the degree of anemia. It may be around 6 to 8%. You find the nucleated RBC, target cells, microcytosis, elevated serum bilirubin, and serum iron is elevated. Total iron binding capacity is reduced. Bone marrow shows bone marrow hyperplasia. Radiographs show the widening of the diplo with hair and appearance of the X-ray skull. And HB electrophoresis is diagnostic. There is elevated fetal hemoglobin pattern and fetal hemoglobin and adult hemoglobin pattern with high fetal hemoglobin and low adult hemoglobin. There is FAA2 pattern in the form of elevated fetal hemoglobin, then less adult hemoglobin, and elevated A2 levels. It is said nearly 100,000 thalassemia major patients are there in India with over 35 million carriers. This is the hemoglobin electrophoresis with elevated HbF level. This is the pattern you see in the hemoglobin electrophoresis. And this is the child getting regular transfusion therapy for beta thalassemia. So what are the steps of management? Treat the patient with regular transfusion therapy, provide folic acid, hydroxyurea, avoid iron-containing foods, counsel the parents to avoid the iron-containing foods, and encourage them to provide nutritious diet to the child. Iron chelation with deferoxamine and deferriprone or deferoxyrox, splenectomy, and ultimately stem cell transplantation, that is hematopoietic stem cell transplantation. Then coming to transfusion therapy, the patient should be put on regular transfusion therapy from the age as early as infancy, that is after 6 months of age. It is a challenging decision because it is going to result in hemosiderosis due to iron overload, secondary to regular transfusions, because one transfusion is going to add nearly 250 milligrams of iron to the body. There is no exit for the iron from the body, so it gets accumulated in the tissues. And regular transfusion is going to promote growth and prevent bony changes, correct anemia, and maintain the hemoglobin at 9.5 to 10 grams per cent to get these beneficial effects. Give the blood transfusion at the intervals of 3 to 4 weeks, no matter you treat the iron overload with chelation therapy. Hydroxyurea has got limited reports for use in thalassemia major, but it has been tried in thalassemia intermedia in low doses, that is around 10 milligrams per kg per day. With improvement in hemoglobin, reduces the chances of venous thrombosis. This is the beneficial effect of hydroxyurea. But do not give in high doses. It results in toxic agranulocytosis. And provide iron chelation. When serum ferritin levels go up beyond 1000 nanograms per ml, hepatic iron, which is assessed after 1 year of transfusion therapy, it is more than 2500 micrograms per gram weight of the liver. But if you start chelation, it becomes toxic if the iron levels are low. Iron stores are low, yes. And you have got deferoxamine, which is the commonly used drug with good therapeutic results, given in a dose of 20 milligrams per kg per day, gradually increased to 60 milligrams per kg per day, given subcutaneously or IV. Okay, deferoxyrox is orally given chelating agent in a dose of 25 milligrams per kg per day. Deferriprone is given for cardiac hemosiderosis at a dose of 20 milligrams per kg per day. There is ultimate treatment is hematopoietic stem cell transplantation. Well, in our poor country, and there is Thalassemia cases are there more in the tribal areas, and that particular population is far away from the advanced medical services, and the hemopoietic stem cell transplantation for these patients is the dream to come true in our developing country. And these children with these chronic hemolytic anemia due to genetic mutations, they suffer great degree of morbidity and mortality. Okay. Well, anyway, hemopoietic stem cell transplantation is going to give cure rate of nearly 90% when performed under 15 years of age, with no evidence of hepatomegaly and no excessive iron stores. So the children who are going to who are planned for transplantation should be monitored for hepatomegaly and iron stores. You should get HLA matched sibling in order to promise the success of stem cell transplantation with hemopoietic stem cells. Then splenectomy is advised for patients with massive splenomegaly and recurrent episodes of hypersplenism, which results in falling hemoglobin, raising frequency of transfusion. Okay, partial or total splenectomy is advised in these situations, but there is risk of sepsis, which has to be prevented by adequate immunization against the capsular bacteria. And you give the pneumococcal vaccine, give regularly flu shot every year, and encourage the parents, counsel the parents to provide the adequate care with regard to the hygiene and sanitation, avoid overcrowding, avoid exposure to the patients with throat infections or the other infectious diseases. Well, the risk is sepsis, venous thrombosis, stroke, leg ulcers, and pulmonary hypertension following splenectomy. So the parents have to be adequately counseled, explained thoroughly for these risks following splenectomy. Then monitor the cardiac function regularly and assess the cardiac hemosiderosis by MRI after 8 years of continuous transfusion therapy. Following 3 to 5 years of transfusion therapy, evaluate the endocrine function with regard to pancreatic, growth hormone, thyroid functions, etc. And psychological counseling and supporting the family is paramount importance in order to effectively manage these patients with thalassemia major. Thank you very much for patient listening, and we'll meet you again in the next class. Until that time, thank you and bye-bye. సేవ్ చేయలేదా? అయ్యయ్యయ్యయ్యయ్యో. వెళ్ళిపోయింది. అయ్యయ్యయ్యయ్యయ్యయ్యయ్యో. అమ్మమ్మమ్మమ్మమ్మమ్మ. ఏ అంకమ్మ. ఓ ఇది ఉందండి.